Hello, everyone. Today, we'll be discussing this research that was conducted by Lovell et al. In the year 2006. We come across this research while studying for obsessive compulsive disorders, being more specific, while studying for the treatment and management of obsessive compulsive disorders. Having a look at the title of the study over here reads Treatment of Obsessive Compulsive Disorder Using Telephone Administered CBT. So, we're talking about a comparison between CBT being administered face to face versus CBT being administered through telephone. This is what I'm talking about. We talk about a comparison, or we talk about the effectiveness of CBT being conducted either face to face or being conducted or administered through telephone. Without any further ado, let's begin with this research. Since this is a key study, I always recommend students to lay more emphasis on this to study this in a better manner. In other words, to make sure that they're not missing on any details while preparing for this particular research. Now, if we talk about this key study, initially we discuss the context of the study, then we move on towards the main theories and explanations, followed by aim, followed by study design, followed by results. Having looked at the context of the study, research, including from the UK's National Institute for Clinical Excellence, that is NICE, shows that CBT is an effective treatment for OCD. CBT has always been seen as a very effective treatment for OCD. Now, the question that arises over here is, would telephonic CBT be as good as CBT being administered face to face? Taking this ahead, traditional CBT involves weekly face to face sessions of 45 to 60 minutes over several weeks. However, this approach can be seen by many as being costly, time consuming, and often results in long waiting lists. Now, if I talk about this part over here, I'm sure everyone would agree, as effective as CBT has been, since I mean there is a lot of data, there is a lot of research that shows us that CBT has been a very effective way to treat individuals with OCD. But at the same time, if you talk about traditional, typical, conventional ways of using CBT, they might be seen by many as being very costly. Costly as in maybe someone lives in a rural area and it might not be easy for that particular person to commute to the therapist every now and then. Because remember, CBT expects, or cognitive behavioral therapy, like many other psychological therapies, they're very demanding. They expect the patient to visit the therapist, and it has to be a very strict routine. So this might turn out to be very costly, might be very time consuming in the sense that it might not really work out well with the daily routine or the schedule or the working hours of an individual. And at the same time, this could result in a long waiting list too. Imagine the amount of rush, imagine the amount of queue that an individual who already does have OCD has to go through. And this just makes the symptoms worse for the individual, because remember, we're not talking about a normal individual, we're talking about an individual who already suffers from OCD. So delays in treatment can lead to worsening symptoms, making OCD harder to treat and increasing therapy time, which further adds to the waiting list. To address this particular issue, there have been many alternatives that have been developed over the years. Amongst these alternatives, we have computerized CBT being administered. We have self-facilitated or facilitated self-help CBT being administered. And in line with this, today we'd be talking about how effective telephone-administered CBT is. Now, bear this thing in mind. This study was conducted in the year 2006. And as I speak right now, that's around 18 years ago. Taking this ahead, if we move on towards the main theories and explanations for this particular research, providing CBT over phone has several advantages. Let's discuss the advantages here. Number one, shorter telephone sessions can reduce waiting lists compared to traditional face-to-face therapy, benefiting patients by shortening the wait for treatment and easing the strain on CBT providers. So yes, if you do not have to, if you're a CBT therapist, if you're a CBT provider, if you do not have to accommodate every individual at your clinic, that would ease out the process for the therapist as well. So telephone CBT also makes therapy more accessible for patients. That's a very big advantage. Accessibility. Telephonic CBT makes therapy more accessible for patients who may lack transport, struggle to afford travel costs, or have difficulty fitting in weekly appointments around work, family, or other commitments. For individuals with OCD, telephone sessions are especially helpful, as traveling to unfamiliar environments for face to face therapy can be anxiety provoking. Like I mentioned a minute ago, we're talking about people who are suffering from OCD. For them to have to travel to an unfamiliar environment might be very anxiety provoking. Now, has there been any research prior to this research that is a part of our syllabus that could support this idea? Oh, yes, there have been. So there are two key researches that I'd advise you to learn as well. This first research that was conducted by Moore et al. In the year 2000, they noted a rise in phone delivered CBT, offering more accessible support for those unable to attend clinics. So, what we're talking about over here is an increase in phone delivered CBT. Why an increase in phone delivered CBT? Because this perhaps increased accessibility for patients. One. Number two, another reference over here that was by Taylor et al. In the year 2003. Taylor et al. In 2003 found telephone CBT to be effective and more affordable compared to traditional face-to-face therapy, making it a valued option for treating OCD. Now, having said that, let's move on towards the aim of the study. The aim was to compare the effectiveness of CBT carried out by telephone with CBT carried out face to face in the treatment of obsessive compulsive disorders. It was hypothesized that outcomes would be similar for both methods used. Now, what the hypothesis that we're talking about over here is a directional hypothesis. Why is it a directional hypothesis? Because the researchers are very clearly predicting what they're looking forward towards. The prediction over here is that telephonic CBT would be as effective as face-to-face CBT. So a one-tailed hypothesis, also referred to as a directional hypothesis. Moving on towards the study design. About this particular research, this is referred to as a randomized control trial. Now, what does it mean when we use the word a randomized control trial? We're referring to the term randomized control trial over here because the participants or the patients the patients who were a part of this particular research, they were randomly allocated to either the face-to-face administered CBT group or the telephonic administered CBT group. And this, of course, adds on to the credibility. This, of course, adds on to the internal validity of the research. So, a randomized control trial compared exposure and response prevention therapy delivered through 60-minute face-to-face sessions or shorter telephonic sessions up to 30 minutes. Now, we're talking about two independent variables over here. The first independent variable was CBT being administered face to face, and the second independent variable was CBT being administered through telephone. The face to face session lasted for 60 minutes, and on the other hand, the telephonic session lasted for up to 30 minutes. Each group received 10 weekly sessions. The sample each group received 10 weekly sessions. However, I'd like to add up something to this. When we talk about the telephonic group, for the telephonic group, it worked like this. The first session was face-to-face. From the second to the ninth session, they were administered through telephone. And the last, that is the 10th session, this was supposed to be face-to-face as well. Now just add this little piece of information. Now, moving on, the sample included 72 participants. There were 72 participants in total. These participants were from UK. Now, if you want to evaluate this research, remember researches that have been, or a research that has been conducted in UK, the extent to which the findings of this research might be questioned by many, because yes, there might be cultural differences that might emerge as well if you talk about a comparison with individuals from other countries. So the sample included 72 participants from the UK aged between 16 to 65. That looks a pretty decent age bracket. They were all clinically diagnosed with OCD. One. Now, if you talk about the recruitment criteria over here, all of these patients, they have to have they had to be clinically diagnosed with OCD. One, the participants should have scored at least 16 on the Yale Brown Obsessive Compulsive Scale. That is the second recruitment criteria. And the third one was they did not have any substance misuse or severe depressive disorders. So let's divide the recruitment criteria into three parts. That would make it easier for us to understand and then memorize the study as well. The first part over here is all of these participants, they had to be clinically diagnosed with OCD, number one. Number two, they had to have at least a 16-point score on the YBOCS, and they did not, and they should not have had substance misuse or severe depressive disorder. Moving on, these participants, like we discussed earlier, they were randomly assigned to either the telephone or the face-to-face condition. Now, this random allocation adds on value, adds on credibility, adds on to the internal validity of this particular research. Validity of this particular research. So participants were randomly assigned to either the telephone or face-to-face condition, creating an independent measures design. Now, an independent measures design, when I use the word independent measures design over here, an independent measures design is when different participants are made to go through different experimental conditions. And of course, in this situation that we're referring to over here, we're talking about the first group being the group that was administered CBT face to face, and then there was this another group that was made to go through OCD, that was administered CBT through telephone. uh, so yeah, so now we're talking about two different groups over here. Since we have two different groups being having to go through two different conditions, it wouldn't be wrong for us to refer to this particular research or this particular experimental design as an independent measures design. Now, bear this thing in mind when you talk about independent measures design over here, the possible pros and cons that you could link to this particular study should not be ignored too. For instance, now we're talking about different individuals being allocated to different conditions. What about participant variables amongst them? So moving on. Two experienced therapists. Of course, if you're using experienced therapists, you are adding value to the research. Again, you are trying to cater to the ethical guidelines. Two experienced therapists conducted the session at separate clinics. Now, you are collecting data from separate clinics, which again is a good thing, ensuring consistency. Now, where there's consistency, there's a standardized procedure being used. Where there's a standardized procedure being used, the likelihood of your study being replicable increases. When the likelihood of your study being replicable increases, automatically the chances of your reliability increase. The chances of your reliability increase. So two experienced therapists conducted this session at separate clinics, ensuring consistency with therapist manuals, supervision every 2 weeks, and 4 monthly training sessions. Before the treatment, participants were assessed twice, 4 weeks apart, using the YBOCS. So these participants, they were assessed 2 weeks prior to the treatment as well, because guess what? You require a baseline. You ought to make a comparison because you want to see if the methods that you were using were effective at all. So for the baseline before the treatment, these participants were assessed twice. Do not forget this. These participants, they were assessed twice, 4 weeks apart, using the YBOCS and the BDI. YBOCS is Yale Brown Obsessive Compulsive Scale, and BDI is Beck Depression Inventory. Bear this thing in mind, they're both very popular, very credible, very valid measures that are used by psychologists worldwide. So participants were assessed again after treatment and at 1, 3, and 6 month follow-up. So prior to the treatment, data was collected twice. This data that was collected twice was done so by the usage of YBOCS and BDI. And after the treatment, the data was collected 4 times. Once right after the treatment, the second one was after 1 month, the third one was after 3 months, and the fourth one was after 6 months follow-ups using the same measures, that is YBOCS and BDI. Along with using YBOCS and BDI, a client satisfaction questionnaire was used as well. Now, when we're talking about a client satisfaction questionnaire over here, of course, you want to see how satisfied the client felt, how satisfied your client felt when it came to being treated through both of these different methods. The researchers conducting assessments were blinded to the participants' assigned condition to prevent bias. Now, of course, Many students, I've seen them getting confused with this, and they might end up referring to this as a double blind design. No, this was not a double blind design, because of course the people who were administered CBT through telephone, they would know that they're being administered CBT through telephone. What When we talk about when we're talking about the assessment procedure being blinded, what we actually mean over here is the data that was collected. Whoever did assess the data, they did not know if the particular data that they were assessing was from a patient who had been administered CBT through a telephone, or a patient who had been administered CBT face to face. So the researchers conducting assessments were blinded to the participants' assigned condition to prevent bias. Taking this ahead, if we quickly move on towards the results of the study, like I said, before the treatment, the mean YBOCS score was 25. Now, we're talking about scoring over here. And if we talk about scores, we're of course referring to quantitative data. So before, and of course, when I use the word quantitative data, all the pros, the cons, the strengths, the limitations have to be kept in mind, because this helps you evaluate the study in a better manner. Now, when you talk about the usage of quantitative data, of course, quantitative data is easier when it comes to comparison. And moving on, before treatment, the mean YBOCS score was 25, indicating severe OCD. There was no significant difference in YBOCS or BDI scores between the telephone and the face-to-face groups before treatment. In other words, what we're talking about over here is that the baseline was pretty similar, as in it's more like you comparing an apple with an apple. So you did not have a very marked difference when it came to baseline or the data being collected before the treatment. Moving on, at all four assessment points, that is right after the treatment, 1 month after the treatment, 3 months after the treatment, and 6 months later, clinical outcomes were equivalent for both. So, yeah, as hypothesized, remember the researchers had expected that the effectiveness of CBT being administered through telephone would be similar to CBT being administered face to face. Moving on to the third point, YBOCS scores dropped significantly after treating for both conditions. A treatment was considered clinically relevant. Now, we're talking about operationalizing. When you talk about there being a significant difference, or when we talk about these both of these methods being effective, what particular criteria were you using? For this, you need to operationalize what you mean when you use the word reduction, or when you say the YBOCS scores dropped. So a treatment was considered clinically relevant if the YBOCS scores decreased by 2 standard deviations or more. This is important. Do not miss on this. So this is how the researchers set up a cutoff criteria. This is how the researchers operationalized a drop in scores. This is how the researchers defined what reduction in OCD symptoms would be like. So the YBOCS scores had to decrease by 2 standard deviation or more, which occurred in 72 patients. That's quite a number. This occurred in 72 patients. However, this if we talk about a breakup of this, 77% of them were from the telephonic group and 67% of them were from the face group. And this already looks like a win-win situation. Moving on, patients reported high satisfaction with their treatment, with similar satisfaction levels across both conditions. Remember, we were collecting, or the researchers were collecting data initially through the YBOCS, along with the BDI, along with the patient satisfaction. I just show it to you, the client satisfaction questionnaire. Now, taking this ahead, what was concluded from here? The researchers concluded that CBT delivered by telephone is as effective as face-to-face CBT, and offers a viable alternative for treating OCD with reduced contact time. So yeah, CBT works out well both through telephone or face to face. However, an added advantage over here is the amount of accessibility telephonic administered CBT increases, or the reduced contact time. There's less of time being spent. This is more accessible. This is a more cost effective manner. This is a more cost effective way as well. So if we have a look at the changes, in scores on the YBOCS, this might help you understand it better. So face-to-face delivery, We're talking about differences over here in terms of YBOCS and BDI, a comparison between the first visit to 6-month follow-up. Taking this ahead, this would show us a decrease in depression too. So this was the baseline. Remember, data was collected twice before the treatment, and this is right after the treatment, 1 month after the treatment, 3 months after the treatment, and 6 months after the treatment. Taking this ahead, let's evaluate this research. As we evaluate this particular study, Lovell et al. In 2006 used an independent measures experimental design. So when you're using an independent measures experimental design, automatically you are eliminating the chances of order effect, because the participants would be going through a single condition, because each group would be going through a different experimental condition. So Lovell et al. In 2006 used an independent measures design where participants were randomly assigned to either face-to-face CBT or telephone CBT. Random allocation prevented researcher bias. So if this is preventing researcher bias, this is making the findings of the research relatively more objective, as the researchers did not choose who went into each group. So it was not the researchers who chose what particular group should be or would be assigned to the participants. The face-to-face CBT group acted as a control group over here, allowing a comparison of telephone therapy with standard CBT. Both conditions had the same therapy duration and outcomes were measured using validated scales. So if both the conditions had the same therapy duration, this would add on to standardization, which again adds on to chance of replication, which increases the chance of reliability. And outcomes were measured using validated scales. Now, outcomes were measured using validated scales. These scales we're talking about were the YBOCS and the BDI. This ensures high validity and high reliability. Now, if I talk about the validity over here a little more, if we talk about the types of validity, I'd like to say internal validity increased over here because the study employed a randomized control trial. When you're employing a randomized control trial, this reduces the likelihood of confounding variables affecting the results. By randomly assigning participants to telephone or face-to-face CBT, the study ensured that differences in outcomes were likely due to the therapy delivery methods. Likewise, if I take this a little further, I could say that this study had high ecological validity too. Now, why is it that I'm saying that this study had high ecological validity? I just write these down so that you might want to put them to use. The first type of validity that I spoke about was internal validity. The second one that I'm bringing in under discussion over here is ecological validity. As we speak about ecological validity over here, the study used real patients with OCD undergoing treatment in clinical settings. Now, this reflects real world scenarios. This increases the applicability of the findings to everyday mental health care, which is again a plus point. Moving on, remember, I just spoke about these two measures, the YBOCS and the BDI being used. Of course, when you talk about both of these measures, like I said, they're both very renowned and validated tools. This would add up to the construct validity of this research as well. This would add up to the construct validity of this research. So the study used well-established and validated tools such as the YBOCS and BDI to measure OCD symptoms and depressive symptoms. This ensured that the constructs were assessed very accurately. Moving on, if I talk about the external validity, yes, I could add on external validity to this as well. If I talk about external validity over here, the findings of this research have broad implications. We need to understand this. The findings of this research have broad implications for increasing access to therapy, particularly for those unable to attend face-to-face sessions. This would automatically increase the generalizability of telephonic CBT to a more diverse population and more diverse settings. So this could be used, this could be used, this could be used, and this could be used as well. Moving on. A limitation of the study is its small sample size. Remember, there were only 72 participants that were there, and the sample size was relatively small. There could be cultural or socioeconomic differences amongst participants that were not in particular addressed in this particular research. So this limits the extent to which the findings can be generalized across all populations with OCD as well. Taking this ahead, a limitation of a study is its small sample size and the fact that all participants were from the UK, which limits the generalizability of the findings. Again, the use of self-report measures could also lower validity as participants' response might not be accurate. Remember, self-report measures, while using self-report measures, you can never be sure, you can never be certain about the responses you receive. So self-reports are considered to be subjective and participants may exaggerate or underestimate their symptoms. Again, these were a few strengths and weaknesses of the study. We could add on more to these. If we talk about the practical application of this particular study, Lovell et al.'s findings have practical applications in real life. Their research shows that telephone CBT is a cheaper and more accessible alternative to face-to-face CBT while being equally effective. This benefits providers such as the NHS. Now, talking about the NHS over here, let me just add. Now, this adds on to the temporal validity of the study as well. The temporal validity. So this benefits providers such as the NHS, National Health Services, as reduced contact time makes telephone CBT more cost effective, allowing resources to stretch further. Patients could also benefit because it improves accessibility, particularly for individuals who struggle to leave their homes. Additionally, telephone CBT can reduce waiting times, helping patients receive treatment sooner too. So talking about temporal validity over here, we could also say that this study's findings remain relevant even today too. So remember, like I said, the study was conducted in the year 2006. If you talk about its relevance, it can be seen as being pretty relevant today as well. We could say this is pretty relevant even today, as the use of teletherapy has increased significantly, particularly during and after COVID-19 pandemic. Now, this study anticipated a growing trend in remote mental health care, which is again adding on, or rather say, giving this a +2. Moving on, if I talk about, so we've spoken about different types of validity. Now remember, these different type of validity, I mean, you could write down against them too. If I think I just add that part as over here as well. So when we talk about this particular study, we could also say that self-report measures like the YBOCS and BDI may introduce response bias, right? So when I say there are certain things that add on to the internal validity of the study, this again reduces the internal validity of the study. So this, I just write it down, this decreases internal validity too. Using random allocation would increase internal validity. So using random allocation might increase internal validity. And at the same time, using self-report measures we could say can decrease internal validity. So is the case with, if I talk about ecological validity, we could also say that telephone-administered therapy may not fully replicate all world scenarios where non-verbal cues, when you talk about a face-to-face interaction, along with verbal communication, there's non-verbal communication too. Non-verbal communication such as the individual or the therapist's body language, their demeanor, their facial expressions, their eye contact, their likability, all of these could be the attire, maybe all of these could be seen as non-verbal cues too. So telephone administered or telephone delivered therapy may not fully replicate all real world scenarios when non-verbal cues play a role in face-to-face interactions. This automatically would limit the ecological validity for this particular research. So as much as we can say that the ecological validity of this particular research increased because they were real patients, but at the same time, there are certain limitations that we should keep in mind as well. So is the case with construct validity. We just spoke about how construct validity of this particular research was high, because renowned scales such as the YBOCS and the BDI were used. But at the same time, the reliance on telephone communication could affect the therapist patient dynamic, because remember, they are not sitting right in front of each other. Remember, this is being administered through an alternative method over here. So saying that the reliance on telephone communication could affect the therapist and patient dynamic, which might impact the therapy's effectiveness in ways that are not fully captured by the outcome measures. So there's a possibility that just because there was CBT being administered through telephone, the patient and the therapist dynamics might have changed. Now, taking this a little further, again, like I said, the external validity of this research, we had spoken about how the external validity of this research had improved, but at the same time, by just having 72 participants over here, this we spoke about this over here, by just having 72 participants, this might limit a few things as well. So moving on, if we talk about how this study very importantly highlights the debate between biological and psychological treatments. So psychological treatments like CBT help patients address the root cause of their problems and develop reusable coping techniques, fostering a sense of responsibility in their recovery. And in contrast, biological treatments such as antidepressants or antipsychotics are often faster, easier, and cheaper, making them more appealing. Now, Lovell et al.'s work bridges this gap by providing a cost-effective, quicker alternative to traditional CBT, combining some benefits of both approaches. Now, I hope this has been helpful. If we try concluding this research, we could say that Lovell et al. Demonstrated good internal and ecological validity by employing a rigorous design and focusing on real world applications. However, limitations in external and construct validity highlight areas for future research, such as using a larger sample that is maybe more diverse, that could help us explore the therapist patient dynamic in telephone therapy as well. So all in all, it wouldn't be wrong to say that telephone therapy is equally effective and at the same time does what it is supposed to do in a shorter duration of time, while at the same time maintaining the client satisfaction. I hope this has been helpful. Thank you.